Yes.
Yes.
Wonderful, wonderful. Great, so let us proceed. Forecasting and quantification of health commodities. The main objective of this webinar is just to review the module and ask any questions that can be clarified while we are here. Okay, so quantification. What are we trying to do? What are we trying to do in quantification? I think some of my slides are missing. I don't know why. Okay. In quantification, we are trying to get the right medicine in the right quantity to the right patient at the right time, in the right condition, and at the right price. And all of this has to be done. In order for us to do this, we must, as accurately as we can, quantify the amount of medicines that is required in our country. So we have the words forecasting and quantification. What are these? So forecasting and quantification we use interchangeably, but they're actually quite different. They are both part of the logistics cycle. So what is forecasting? Forecasting is a long-term projection of the future needs of your country. It may take 1.5 years or even 5 years forecast for pharmaceuticals. It depends on the financial situation of your country. The Organization of the Eastern Caribbean States Pooled Procurement Service, of which we are a part, it is of 9 countries in the Caribbean, has a forecasting period of 2 years. Within that forecasted period, then we have scheduled orders which are placed to meet the pharmaceutical demands of all 9 countries. What is quantification? Quantification is the process of estimating the quantities and the cost of the products required for a specific health program or a service, and determining when these products should be delivered to ensure that there is an uninterrupted supply for the program. The results of a quantification period should be revisited and updated every 6 months or more frequently for programs that are growing rapidly or for changing in the programs, the dynamics according to the situation as it demands. So there are 4 methods of quantification: consumption method, morbidity method, proxy consumption method, and service level projection of budget requirements. And these are some of the records. So the consumption method uses records of past consumption, making adjustments for stockouts and the projected needs of medicine use to cover future needs. As you can see, taken from management access to medicines and health technologies, this is what the formulations for doing consumption methods look like. So we have Formula 1, the adjusted average monthly consumption. Formula 2, it is the same thing, but this is the alternative method. Formula 3, the projected average monthly consumption. 4, the basic stock requirements, how to calculate it. So as you see, the formulations are on top and the definitions for the symbols are at the bottom. So once you have your figures and you plug them in, then you can arrive at those figures. Okay. My slide has stuck. I apologize once again. So here we have now the morbidity method. The morbidity method estimates the needs for specific pharmaceuticals based on the expected number of patients, the incidence of diseases, and the standard treatment guides. Hello? You were saying something?
Your slide is still, it has not moved.
Oh, it is moving on my screen. Is it moving now?
Yeah, now it
Yeah,
has moved. Yeah.
now it's moving.
Okay, great. Let me go back to the morbidity method. So here we have taken from management access to medicines and health technologies. Again, we have the formulas with the symbols. And once you plug in the amount, the numbers, then you can arrive at those. So we have formula 1, quantity of medicines needed per treatment episode. QE equals to DCU times ND times LD. So once you plug those factors in, then you would be able to arrive at your morbidity calculations. So what are the other methods of quantification? We have the proximity consumption method, which use data on disease incidence, medicine consumption, demand or use, and pharmaceutical expenditure from a standard supply system and extrapolates the consumption to the target supply system based on population coverage or service level to be provided. Then we also have the service level projection of budget requirements. This method uses the average medical cost per attendant or bed days in different types of health facilities in a standard system to project medicines costs in a similar health facilities. So you can take it from one to the next and you can get your figures on that. So here we have now quantification, comparison. Let me see if I can get that slide in. Okay, great. So here it's gone. Yes, open up. Okay, I'm sorry. I will have to send that because it is opening and closing, where we have the comparison of the methods, the advantages and disadvantages. Okay. So in order to help us now with technology, we do have some software programs that can assist us. So ProQ quantifies HIV test requirements. Quantimed calculates forecasting quantities. The CHI forecasting tools with the Clinton Health Access Initiative developed an Excel spreadsheet for adults and pediatric ARVs and laboratory supplies. However, even with the best software program, we have to remember GEICO. Garbage in, garbage comes out. So we can see therefore that quantification is very dependent on our data. So what do we need? We need the institutional capacity to conduct procurement, supply management. So what do we need? Our management capacity, do we have it? Do we have people in places? Do we have the resources that we need, the infrastructure that we need? Do we have the procurement policies and systems? Do we have our quality assurance programs up and running? Will we be adherent to international and national laws? Do we have coordination within the institution and within the country? And do we have the management information supplies, systems running? Are they ready? We also need to have the procurement cycle, the product selection, the forecasting procedures, the procurement actual, or inventory management, first expired, first out, distribution. Do we have all of those covered? Do we have enough vans to take them to satellite locations? Ensuring rational use. Do we have our standard treatment guidelines up and running? Do we have adherence to that? Are we doing patient education? All of that is needed. So is quantification hard? Yes, quantification is hard. Why? There are so many factors to consider. The lead time, the time taken between deciding when to resupply, when that is needed, with the medicine reaching the patient, for the public sector institutional system. This is typically in excess of 12 months. So now we have to figure all of this. 12 months, 24 months, do we have the finance? Will it reach in time? So we must achieve the 6 rights. as alluded to before, the right time, the right quantity, the right patient, etc. But now we have these months to consider as well. And lead time can be variable, especially now that we are going through with the COVID. Fuel prices are high. I don't know about you, but flights are erratic where we are. Transportation, these are things that need to be considered. Data, do we have the correct data? Most public health sectors do not have reliable data on which we can proceed. So what will we do? Where, how much will it cost us? Do we have the data that we can extrapolate and calculate that fact? Do we have the staff to do the quantification? Because quantification is a multidisciplinary combination of individuals working together to achieve that goal, the 6 rights. So very few PSM staff have been trained adequately in the techniques of medical product quantification. Training is definitely a plus. The right time. Most dispensing sites have very limited storage capacity, but a high throughput of patients. So we do have a mismatch right here, but we need to get it right again for the 6 rights in order to have successful quantification. A World Health Organization survey in 2009 revealed that 38% of the 94 reporting countries had documented at least one stockout of ARVs in health facilities. The right timing. Ensuring a reliable supply requires risk management approach of identifying and mitigating risk. What about our business continuity plan? Is that in place? Because we have to reduce the risk that can occur with our inventory. How many pharmacists do we have trained in risk management? Is that a part of our current curriculum? These are factors that we must consider and factors that can make quantification accurate. We also need to consider the right price. Should we go with generic or brand? If we choose to go with brand, how much generic opportunity are we giving up to purchase so that we can reach more patients? As we know, the brand, is expensive, whereas the generic can be half of the price, which means we can get twice as much pharmaceuticals. We can buy more. So we reduce the possibility of having stockouts. So we have to consider the right price. What is the financial status of our country? Cost predictions, they are very erratic at times. It may start out expensive, then come less expensive. Can we consider the factor if a program is being phased out, then what do we do? So achieving effective and efficient, appropriate quantification. Achieving effective quantification is very challenging, but we have established and proven evidence-based policy methods and mechanisms that work and which can be very successful in their outcomes. These mechanisms require the use of formal systems that have already been established, using a total systems approach, getting everybody involved, all the systems involved that fully recognize that interlinking and interdependent nature of procurement and supply management functions. Although there may be different functions, they all come together in order to achieve effective and accurate quantification. If we look at the diagram, which is sourced from Quantification of Health Commodities, and we can see all the factors that go into quantification. So we have preparation. We need to describe the program, define the scope and purpose of the quantification, collect the required data. Then we have forecasting, we have supply planning. Are the funds sufficient? What are the quantities that we need? Can we mobilize additional resources if they are insufficient? can we increase the funding? Then we adjust our forecasting assumption to ensure that the quantification is accurate and it meets the needs of our countries and our patients. And here are some resources where we can find more on quantification. I know our time is reduced because of my technical difficulties, but we have the management access to medicines and technologies, estimating drug requirement, first published in 1988. So quantification is not new. But from then in 1992 up until now, we have many, many publications on quantification. The Logistics Handbook, which was first published in 1998, Quantification of Health Commodities, published in 2014. So we can look at those resources, get them off the net, and continue and look and see and improve our skills in quantification. It's not new, like I said, 3,000 years old going back, but quantification is needed in order to fulfill our mandate in providing quality supplies in the quantity that is needed. At this time, do you have any questions? If not, we can proceed. So why do we need to learn all of this? Because of course we have computers now. So I don't really need to learn all of this, but no, remember garbage in, garbage out. Computers cannot do effective quantification if they do not have the data to manipulate. So what are the two reasons? We need live wire, we need you, we need me, we need people. The computer can process data, but it will not do the thinking. You will still need to decide the quality and the reliability of the data, and if in the end result makes sense and practical, such as a pipeline, which is an excellent piece of software. It will do the numbers and produce pretty graphs and charts, but it will not document the quantification process. It will not assess the reliability of the data used. It will not explain the assumption used, and it will not cross-check the end results, which is very pertinent. Garbage in, garbage out. Often the data needed for computer processing is either not available at all or is unreliable and incomplete. And here is where we come in. Even artificial intelligence cannot make sense of garbage. So we have to be sure of the information that we are inputting into the computer system in order for accurate quantification. So formal methods of quantification. The World Health Organization Manual Estimating Drug Requirements, or as I said, the WHO, discusses how to develop a good action plan and manage the quantification process. Now, it's rather, I don't want to say old, but the advice is still firm. Then we have the Managing Drug Supplies, the Logistic Handbook, and the Supply Chain Manager's Handbook. This is an excellent resource from which you can glean the information that is needed. We can go on to more of specialist commodities, supply planning, HIV test kits, malaria, the strengthening pharmaceutical supplies, these manuals, all of them, if resourced and if read, can give you more insight in quantification. So how do you know if quantification training is working? Let us look at our COVID quantification. As we know, COVID has changed our reality quite a bit since 2 years ago. The World Health Organization Essential Supply Forecasting Tools, or Esft, for COVID commodities. What are the key characteristics? The WHO Esft is meant to help countries forecast essential supplies for their COVID-19 response, including our PPEs, or masks or gloves, biomedical equipment for case management, or ventilators or oxygen concentrators, the diagnostic reagents and equipment, essential drugs for supportive care, and consumable supplies. So this program was specifically developed in an Excel-based workbook for morbidity quantification. Remember, we spoke about the 4 consumption methods, and morbidity-based was one. The quantities needed per day per health worker. All the algorithms are preloaded, so this program does the quantification for us. But remember, it is dependent on the information that is input into the data if what we get out is reliable for us to make decisions. So, what is the evidence from the Esft? The go on and all the stuff. If you can look at the diagram and we can look at the various countries, we can see which country had the greatest difficulty with quantification. The training requirements, the flexibility, the language needs, the range of commodities, the accuracy of quantities. Do we have a sufficient budget? So countries who choose not to use this tool had difficulty in obtaining funding, but countries who use the tool did very well. So the tool was considered to be good. It is accurate, covered a full range of commodities, but it needed the skills to use it. So the key message from here is that quantification is not just about numbers. It's an entirely interlinked and coordinated process requiring a team effort and stakeholder engagement. So here we see we have many individuals within the life raft: morbidity quantification, consumption methods, and we have good supply management that is needed, budgetary estimates, the essential medicines concept, the pharmacist, the rational use under the standard treatment guidelines, forecasting, health information system. All of these disciplines have to come together in order to have effective quantification. And when they come together and they work, as the diagram says, we can sail around poor diagnosis. We can reduce prescriber turnover. We can benefit and implement changing standard treatment guidelines. We can reduce poor compliance from our practitioners with the standard treatment guidelines. Even in changing the disease patterns, we will be able to navigate that successfully. And we would have effective and efficient procurement. We'll have appropriate and adequate pharmaceutical supplies because all of these disciplines came together to produce accurate quantification. So quantification is not done by one man sitting in an office. Quantification is done by a team. So let us look now at our health and monetary impacts. Do they have any impact? Recognize that the health implications and monetary values involved. If we have no program, we have no product. No product, no program. Modern medicines require to have a successful program. So our commodities are typically more than 40% of our total health budget. Health, commodities, pharmaceuticals take up quite a bit of our health budget. So example, for ARVs, if the real need is for 15.3 million bottles of FDC ARVs per annum and quantification makes a 5% error, can that impact us? 5% less than need is 63,750 patients will not receive their ARVs. Can that affect us? Yes, because some will die. 5% more than we need, which is 38,250 bottles. What will happen? Most likely expiry of the items. So we will have a monetary loss. Donors will not be too favorable to give us funding in the future. So we need to have accurate forecasting and accurate quantification in order to have a productive program. So how do we get it right? We need to understand the need for good governance. One of the common ways to promote good governance and aspects of transparency is to have an independent observer take part in the process. How many of your quantification team have an independent observer? Because they are not biased. They will see, they will look and examine the program. So good governance principles will help us. Good governance principles will promote transparency and accountability, equity and fairness. Good governance principles will ensure policy and legal institutional frameworks are established. It will ensure participation by all of members of this team. And hence we would be able to have an accurate quantification process. So do we have management issues? Of course. Of course. So let us change the focus from just mere arithmetic, but also to management. If we remember the chart that we had with all the pharmacists in the whirlpool, and they were accurately and practically and efficiently managing, navigating that whirlpool to produce top quantification. So how do we do that? We first make a quantification plan. WHO Manual in Estimating Drug Requirement has how to develop a good action plan and how to manage the quantification process. We have to estimate the time and resources required to undertake the quantification process. You need to have quantification complete before you have to order the supplies. And good quantification, it takes time, especially to allow for consultation and cross-checking of the calculations. Remember, too much, you have an overstock, expired, you have waste of resources. Too little, individuals may die from the program because of lack of treatment. So how can we do that? Time and resources will be required for developing and organizing the medicines list, collecting data on the supply pipeline, agreeing the procurement period, agreeing the lead time, agreeing the level of safety stock, which is quite important, adjusting for losses and other changes in the data, cross-checking the results of quantification, agreeing on medicine prices sources and estimating total procurement costs, adjusting and reconciling the final quantities. This step is very important, and agreeing rates of program expansion. Should we scale up? Should we scale down? What is happening according to our environment? How will you decide when you have no or unreliable data and lots of different opinions? We need to form Delphic groups. It's impossible. Is it impossible to do all of this for every item? But it must be done. Every item, it must be calculated. Every item has a different lead time, different safety stock. So although it may seem a challenge and overwhelming, it must be done. But it is not difficult. It is possible. It is possible. But in the short to medium term, it is possible to focus our quantification efforts on priority items, and use general conditions, assumptions for groups of other items. No one dies from indigestion, but we will die from lack of antibiotics. So quantification is important, and we must be able to rely on the numbers produced. We also need to look at how we can come about the importance of our pharmaceutical system. So we have the VEN, which is the vital, essential, and non-essential items. And we use this to categorize the importance of the pharmaceuticals that is procured by our system. So the methods help us identify a small group of medicines or health products that have the greatest health impact. Vital, life-saving medicines such as antibiotics, such as a cardiac medication and intravenous solutions, warrant greater attention than other important but not life-saving medications such as analgesics. So we may not die because we didn't have the paracetamol to take, but if we did not have, let us say, a carvedilol to help with the hypertension and our heart, then of course we may die. So we have the VEN, vital, essential, and non-essential, or the VED, vital, essential, and desirable. So who decides the VEN list? The pharmacy, the National Drugs and Therapeutics Committee, which is a multidisciplinary committee of individuals. We have the financial, we have doctors, we have nurses, we have laboratory technicians, we have pharmacists. So a number of countries already include the classification in their essential medicines list and health products. Jamaica has a wonderful system. So let us look at the criteria. The V, which is vital, potentially life-saving, significant withdrawal side effects, and major public health importance, those medicines. The essential ones, effective against less severe, but nevertheless significant form of illness. And non-essential, they're used for minor or self-limiting illnesses. Questionable efficacy, such as cough medicines, do they work? Or high cost for marginal therapeutic advantage. So now let us look at how we do the VEN. So we have the central medicines supply, we have the strength, we have the dosage form, and then we have the VEN. So as we can see, the loperamide has been classified as essential, where the oral hydration solution has been classified as vital. So as we can see, we go down now, we have the glibenclamide as essential, the glycoside as essential, and they have classified their metformin as an essential item. This is an example from Namibia. So another economic importance tool that we can use is an ABC analysis. The ABC analysis can be used to identify those medicines that have the greatest budgetary effect if their quantification is inaccurate. Separating the vital few from the trivial many is the Pareto Principle. It is known as the 80-20 rule, the law of the vital few, and the principle of factor sporacity. It states that for many events, roughly 80% of the effects come from 20% of the causes, the 80-20 rule. As you can see, we have a listing of the isoflurane. It is the A, and all go down are A items. So these are vital items. So what are our key points? Data, no one expects our data to be 100% accurate, but over time, it should improve. But they do expect a realistic assessment of how reliable and how accurate that data is, and a plan to improve our data collection in the future. So what factors shall we look for quality data? should be accurate, should be complete, should be valid, should be consistent. Timeliness is important in data collection, and it should be relevant to the program that we are doing. At the start of a program, it's perhaps acceptable to have 60% of a site reporting. But 5 years within a program, we should have at least 90% of sites within the country reporting on the data that is collected. Our data management needs to improve over time so that we can improve our process. Quantification and forecasting are very heavily reliant on the data that we do collect. So again, at the start of a program, assumptions can be gleaned from other operations because you're just starting your program. But 5 years into that program, you should now be producing some evidence-based data. How many supply programs are even trying to measure their wastage rate after 5 years? At the beginning, it may not have been possible, but after 5 years, you should be able to measure the wastage rate, see where the wastage is occurring so that you can address those issues and have a better program. Not having the information at the start is understandable. Not trying to measure it, that is not acceptable. Computers in quantification. In modern times, the choice is not really about using manual programs or computer methods for quantification, but rather which computer methods are most appropriate. Although excellent software exists for pharmaceutical quantification in new or rapidly scaling up programs, it can often be better to start by using one simple spreadsheet and then move to specific software after a degree of stability is achieved. These are particularly useful in developing the what-if scenarios for projecting budgetary requirements. In cross-checking, never underestimate the value. For example, in one quantification program for intrauterine contraceptive devices, the quality of issued data was considered good and indeed accurate and on point. Accurate records of the stock were given out. However, enough IUDs had been issued for every man, every woman, and every child in that particular aspect. But when you look at the comparison of population, the morbidity data highlighted the problem of leakage and or resale of IUDs outside of the country. So when you put all principles together, you can identify a problem. This comparison produced a more accurate quantification for the next year's supply. So cross-checking is vital in order for improvement in your program. That is the example of a quantification report. You can use the CHI tool for quantification of the pediatric ARVs. So the summary, fundamentally, quantification is a management process. In the past, too much emphasis has been placed on the mechanisms of calculations and not enough on managing the process. Managing is essential. Quantification training works. Look at the COVID Esft program. Data reliability is a massive problem for many countries, and the need to improve data quality must be recognized and action taken. The Global Fund in particular will not tolerate poor data as an excuse for inaccurate quantification. Hence, in order to qualify for Global Fund grants, we need to have accurate quantification. We need to examine how we collect, what type of data do we have. Good quantification requires real resources and adequate funding, some of which are challenging to many countries. The use of the Venn list or the ABC can help us focus our efforts while we advocate for more resources. do we really need this medicine? Or can we reduce this so that we can use that finance to purchase something that is more critical? Donors will pay for quantification enhancement, quantification process training, but they are almost never asked for. Not even 1% of Global Fund grant applications include a request for funding for quantification, and most don't even mention any funding for PSM at all. Global Fund will pay because quantification can speak to the authenticity of your program. At this time, I pause for any other questions. I thank you for listening. Let me see if I can check the chat.
So, hi Grisha, what a wonderful event. Thank you so much. So now I would request you all, you can please unmute yourself. Feel free to ask questions related to the PPT or the expert session. So go ahead.
Quantification is essential to the success of our programs. I hope that the lecture, the review has been informative in assisting you with module 3.
Hello, good day.
Hello.
Yeah, so this is Christian from Cameroon. Thank you very much for this excellent presentation. It was very helpful for us that are working in supply chain. I had a question. I wanted to hear more about independent observer. So for the quantification, when you say independent observer, is independent vis-a-vis of the country, the donor, or can you tell us more about independent observer?
Well, it will speak, sorry, independent observer will be according to your resources and according to the situation in your country. So it can be someone who is outside from another discipline in the government, who will have an independent eye as to what is happening, or you can request someone from at OECS PPS, Organization of Eastern Caribbean States Pharmaceutical Procurement Service, of which I am a part. The British Virgin Islands is a part with 8 other countries. Usually when we go together at a meeting in St. Lucia, which is the headquarters, to do a tenders adjudication, we have independent observers who examine what we are doing at that time. So it may be a nurse, they are not part of the committee, but it may be somebody of the same discipline. So it could be a nurse who comes in and sits to see how we are going through the process, or it may be a laboratory technician from another part of the government there in St. Lucia. So it is someone who is outside of that committee that you have, who will be considered your independent observer. So if the country can afford to bring in one from another country, well, then you can go ahead and do that. But if finances do not assist, then you can just recruit someone from another part of government who can come in and sit and look at the processes that you're going through. Is that any clearer?
Yes, thank you. Thank you. It was very clear.
Yes, so
Okay, permit me a second question about quantification committee. Do quantification committee should be set up per program or or just for essential medicine widely, or should there be should we have a quantification committee for different programs?
No, your quantification committee can be there to do all of your programs. It doesn't have to be for a specific program. Once that is in place, once the persons are in place and the persons are well trained, then that committee can serve for various functions or various other duties. So you can look at your quantification committee, let us say for pharmaceuticals, and you have those persons in place. You can look at for your laboratory supplies and you have those persons in place. So remember, your quantification exercise is a multidisciplinary committee, and each one of those persons bring their aspect, bring their training, so that you can navigate all of the challenges of quantification.
Okay, got it. Thank you. And the last one, while cross-checking, how do we have any guideline on reconciling the different method used for quantification?
Sorry, can you repeat?
Talking of cross-checking the result at the end of the quantification, I don't know if you have some guideline or it should just be limited to looking at different results from different method used to see whether it's the match or it makes sense.
Yes, you can use another method to cross-check the information gained from one method. So that is one way. If the results don't seem to be too realistic, yes, you can then use another method to cross-check and to see how closely aligned those results are and where adjustments would be necessary. So,
Okay, good afternoon, Mrs. Gracia. Hello.
Hi, yes, good afternoon.
Yeah, this is Odon from South Sudan. Thank you for a wonderful presentation. Mine is just, I want to ask about the tools used in quantification. You said that chai is good for pediatrics ARV. Does it mean that it cannot be used for adult ARVs? And this tool, I think they all look alike. It's just the names which is differentiating them from one to another. Do you agree with me? Thank you.
Yes, I quite agree with you. Basically, the foundation would be similar. It is just the packaging might be different. You know, your Tylenol versus paracetamol versus acetaminophen. So it would just be the name and maybe a little tweaking here and there, but everything with the foundation would be the same. Yes, I quite agree with you.
Hello, good morning.
Good morning.
Thank you so much for the presentation. I'm from the Gambia, but we do have challenge when we are doing the lab quantification. I don't know, do you have any software or any tools that's being used in quantifying lab supplies? Thank you.
I am going to put my email in the chat because there is, but I do not have that at hand now. So you can reach out. You can reach out to me via the email, and I can send that to you. How is that?
Yeah, that's fine. That's fine. Thank you so much.
You're welcome.
Hello, good morning, Gracia.
Good morning.
Oh, thank you for the very nice presentation. My name is Eric Iranzi. I'm based in Rwanda, in Kigali. I have a question about you. You've been talking about reliable data and unreliable data. How do you classify unreliable data, or how can you conclude that these data are reliable or reliable? Thank you.
Well, most importantly, you have to look at your records and identify any gaps that would be in your records. So if you look at your bin cards in the stock room, for instance, is your data reliable? What about date received? What about quantity? Issue data? Is anything missing from that card that you will not be able to identify reliable data? I'm not sure if you're understanding what I'm saying. So if you don't have completeness in data, you have to look also at your source. Where is the data coming from? You have to look at the training of the background of the person. Has that person been trained in assimilating that data? So all of those are factors that can let you to conclude whether or not what you are getting would be reliable. Is it timely? Remember, we looked at the factors. Is it timely? Is it accurate? Does it speak to your program? What is the source? All of those are things you have to consider when you are looking at data. And that can determine if it is reliable or if it is unreliable. Does that help?
Okay, that's help. Thank you.
You're welcome.
Hello. You've talked about the use of the Venn and the ABC analysis during for quantification. So at the point at which the budgetary allocation clashes with the Venn, what are the considerations that you put in place? My name is Daisy from Kenya.
Hi, Daisy. You would need to look at your consumption level all over again. And that would help determine where you can place it. But the VEN is for decision making. The ABC is for more resource allocation. But in reference to treatment for a program, the VEN is the most essential one. So the data that you get after you look at VEN and ABC and you balance it out, you will look at your consumption level to determine what is needed most. And then you can look at your ABC to see where it falls as far as financials are concerned and see how you can balance that out.
Okay, that's noted. Thank you.
You're welcome.
Hello.
Hello.
Yeah, so this is Patrick Abasura from Malawi. I have understood that the main challenge in quantification is to have reliable data. And for developing countries, I think we can just talk for both developing and developed countries. What mechanisms or strategies which we can put in place to make sure that we have such reliable data? I can give an example for 3 tiers store system, whereby it's not easy to have accurate data from the health center, whereby especially to have the reliable data from the health center to be reported to the central medical stores for the quantification.
Okay, thank you so much. If you look in the chat, in the interest of time, if you look in the chat, there is a website that was just put there in reference to factors of quality data, and that should be able to assist you.
All right, thank you.
You're so welcome.
So Gracia, we have few more questions in the chat box. So I would request you if you can just read it out those questions and answer them.
Okay, let me look.
So we have a question from I guess Daisy. Daisy's query you have already solved. Then we have the question from Nasana. Can you check, Grisha?
From Lasana. Good morning, Grace and everyone. In real context, we are often faced with bottlenecks like the level of HR of our context of work or transparency, not in quantification, but I am not sure how to answer this question. Lasana, my email is in the chat. So if you can email me on this, I can get back to you.
So, okay, thank you. So we have another question from Tisho. It's TATESOH.
Yes, establishing assumptions comparable to international standards is very important because that can actually assist us to see how much in line we are with international standards. Just to limit certain assumptions that could be too skewed for realistic standard. We should not really limit the setting of assumptions, but however, in the time that we have relevant to performing these exercises, it may be, what should I say? It may be noticing on us to be as realistic as we can with the assumptions, but not to overburden ourselves because we do not want to draw out the process of quantification. But we need realistic assumptions, realistic standards to ensure that we do not have stockouts or to ensure that we do not have too much expiry stock, because both are essential. Please, can I have the PowerPoint via email? Sure, I will note that and send you the PowerPoint shortly after the session. So it's inn2ms@gmail.com. Or are you going to send the email? Are you going to send the module by email, Priya?
Gracia, I guess I have already sent the PPT on chat, and plus I will be sending the PPT again on email.
Okay.
So I hope that will work.
She has already shared in the chatting box.
The one that has been shared is some of us are unable to download or access the one shared on the chat box.
Okay, so we can have that, Priya, we can have it sent out by email. This session, Priya has said that the recording of this session will be updated to the YouTube channel for Empower. But if you require it before, you can just quickly put your email address in the chat and I will send it to you as soon as the session is concluded. Thank you.
Thank you so much, Gracia. Very well organized session and PPT. And as Gracious already mentioned that yes, the PPT and the recording of the expert session will be updated and will update you as well as soon as the session recording is ready, and the PPT I have already shared with you or in the chat box, so you can just check it out from there. So thank you everyone for joining the session.
Thank you, Priya.
Thank you very much for the informative session.
Thank you so much for taking the time out
Thank
to
you so
attend.
much.
Thank you, Gracia.
Thank you. Thank
You're
you.
welcome. You're welcome. Do have a wonderful rest of the day.
Thank you.